Welcome. My name is Kelly Cox, and I'm Director of Support Groups and Senior Director of Regional Community Workshops here at the International Myeloma Foundation. I've been involved with patients, caregivers, supporters, all my time here at the International Myeloma Foundation, which has been 20 years. This might be about our 120th or 121st Regional Community Workshop, so you can say we kind of know what we're doing, and we're here to help you. Next slide. We could not do this without the general sponsorship that we have from our sponsors. It's Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda Oncology. Now, when we go through these items here and these wonderful, great speakers that we're going to have today, we need your feedback. And the reason we use this feedback is to see how we can do better. So just take a few minutes after the session today, and if you have some pop-up time to do this, because it is incredibly important to us at the IMF. Next slide. All right, today's action-packed show, as they say. We'll start with Maury Gertz. He's an MD at Mayo Clinic, Rochester, Minnesota. Then there'll be some question and answers with the panel. We'll have a little break, meditation and stretch break. Then we'll go into relapse therapy and clinical trials with Dr. Ala Abdullah, who's an MD at the University of Kansas Medical Center. And then we'll go into how to manage myeloma symptoms and side effects with Teresa Micheli. She is on our IMF Nurse Leadership Board. And then we'll have a question and answers and try to get you out of here at 12:30 your time. So without further ado, as they say somewhere, I would like to introduce a friend of mine and someone I've worked with for many years. He's now, Maury, are you about 35 now? Okay.
Next birthday, yes.
All right, good. I just wanted to verify. Well, let's let Maury start, and everyone get your legal pads out and a piece of paper, and let's start the show, as they say.
Okay, hold on, Kelly. I'm getting ready. Just get me full screen, please.
All right.
And we'll start. So I've been asked to discuss multiple myeloma, introductory concepts about the disease and its management, as well as issues with regard to initial therapy. So I'm going to need myself to be full screen. I can't see myself as full screen. Kelly, do you see me full screen?
I do.
Okay, that's perfect then. Thank you. So let's start with this picture right here. This is a picture of a soup bone that you buy in the supermarket. And that soup bone has two parts to it: a thick outer white hard shell that gives the bone its strength. If you have a soup bone like that, you can jump on it, you can throw it against the sidewalk, you won't break that bone, too strong. In the center of the bone, however, that'll be a dark, spongy area that is used to flavor the soup. And although when you buy it in the store, it's kind of a brownish color, the reality is it's undergone oxidation. And in a freshly slaughtered animal, that center inside of the bone is bright red. It's the same color as blood, because inside the bone is the marrow, and that is the garden, and that is the garden that produces all of the blood. And so when you think about the garden of the bone marrow, what you're actually looking at is an area that's divided into specific crops. And if you look at the acreage of an adult's bone marrow in this garden, you'll see that 20% of the acreage is given over to the production of red blood cells. Red blood cells are the carriers of your hemoglobin. They're the delivery packets of oxygen to your tissues so you can generate energy. And if for any reason the number of red blood cells are reduced at 20% in the acreage, we refer to that as being anemic. So anemia is low red blood cells or reduced hemoglobin levels in the blood. 60% of the acreage of that garden are given over to the production of white blood cells. Those are the cells that help you fight off infection. They keep you from getting fevers, bacteria, and 10% of the garden are given over to the production of blood clotting cells. These are the cells that keep you from getting nose bleeding, gum bleeding, easy bruising. And that's the way the garden is 60-20-10. And that's pretty tightly regulated by your body. So that garden is 60-20-10 from the age of 6 months to the age of 96 years. It never changes. In normal adults, 60-20-10. Now, the first thing is that only adds up to 90. So we're missing 10% of that garden acreage. And that 10% is given over to a whole host of boutique garden crops, go by the name of basophils, eosinophils, macrophages. Those boutique crops are not important for our discussion. But what is important for our discussion is a cell that occupies in all normal adults 1% of the acreage of the garden. And those cells are called plasma cells. Everybody has plasma cells. They're 1% of the acreage in normal adults. And they're very important because they produce, and write this down, antibody proteins. Antibody proteins. And these antibody proteins are instrumental in your body's immune system because you make these antibodies, and these antibodies that you're making help protect you against infection. And in fact, when you're immunized against COVID or tetanus, or you scrape your knee and get an infection, these plasma cells, the 1% of the garden acreage, make antibody proteins. And these antibody proteins are found in all normal adults. And there are 4 key antibody proteins, you want to write this down too, that are critical that these plasma cells produce. They're different flavors of antibody proteins. And the 4 that we're going to be focusing on later in the discussion are G, A, kappa, K-A-P-P-A, and lambda, L-A-M-B-D-A. Those are the 4 antibody proteins we're going to be discussing later on in this discussion. Everybody has these proteins in their blood. They can be measured directly by different techniques that I'll be reviewing. And so that's what is normal. You've got 60-20-10, and in a normal adult, 1% of the acreage are these plasma cells. Unfortunately, when cancer develops, a cell in the body, whether that's a breast cell or a prostate or a lung cell or a bone marrow plasma cell, garden cell, becomes malignant. It becomes genetically abnormal, and it develops the characteristics of it has a growth advantage to the other seeds in the garden. The seeds that are growing red cells, white cells, and blood clotting cells, you develop plasma cells that have a growth advantage. And they begin to grow in this bone marrow garden, that center bone marrow area there in that middle. And as they grow, the easiest way to conceptualize what's going on is to think of these as garden weeds. And these weeds will grow over time and begin to increase beyond that 1% acreage. They'll begin to grow 2, 3, 5, 8%. Now, by general agreement among experts, patients who have an overgrowth of these weeds, but less than 10% of the acreage of the garden is replaced, these patients generally are referred to as having MGUS. This is an abnormality where the garden's clearly abnormal, but you're living really quite well with the garden. The garden's not disturbing you. The garden's not bothering you. The weeds are causing no ill effects. You're completely without symptoms. Most of these are detected incidentally as part of an annual checkup. And this MGUS can simply be observed over time to see if changes occur in the weed count. But by general agreement, if the percentage of weeds goes over 10%, we refer to that, if the garden is over 10% weeds, we refer to that as myeloma. Now, myeloma comes in two flavors as well. One is where you've got more than 10% weeds and you feel great, you feel normal. It's a complete surprise that anything's going on and you can barely believe that there's over 10% weeds and no symptoms. And when that happens, we refer to that as smoldering myeloma. But there are patients, when the weeds start to grow significantly, they start to cause problems. So what are the associated problems that cause symptomatic myeloma? And there's really three basic. I'll start with the first two. As the weeds begin to overgrow the garden, they begin to replace the healthy, normal garden plants. This is no different than you've got a garden out back growing tomatoes. As the weeds grow, the yield of tomato plants is going to go down. And so as you grow your garden, which has seeds, seeds give rise to plants, plants bear fruit, and the fruit is your blood. As the weeds begin to choke off the plants, then the yield of fruit goes down and the number of, if you will, bushels of tomatoes per acre begins to decline. Putting this into English, as these weeds grow, it starts to choke off the growth of the red blood cell plants. And so the number of red blood cells, tomatoes, if you will, begins to decline. And what doctors see is there's a decline in the red blood cell count or the hemoglobin count, which we would refer to as being anemia. Anemia is actually present in nearly 70% of patients with multiple myeloma at the time of diagnosis, reflecting the way in which the weeds are choking off the garden plants and causing the yield to go down. The symptoms of anemia are pretty standard: easy fatigability, unusual degrees of tiredness, difficulty with your normal activities. So maybe sitting still, listening to me talk, you feel fine. But if you try to climb a couple flights of stairs, you're much more short of breath than you used to be. If you're walking distance or up an incline, that becomes challenging. If you exercise, whether it's running or walking or bicycling or rowing, you find that your stamina is in decline. And this is a reflection of anemia, low blood, 70% of patients. What's the second problem? Well, first of all, I have to show you another cartoon. That's your spine. This basically, there we go. Your spine, your vertebrae in your back are basically children's building blocks. They're squared off, and one is on top of the other, giving you your vertical height. And just like the soup bone that I showed you, inside each of your vertebrae, there is bone marrow. And so now I've drawn in to this, I've drawn in the bone marrow inside the vertebrae that is also garden inside those spine bones. And what happens in patients with multiple myeloma is these weeds not only overgrow the garden, they'll begin to overgrow the casing of the garden. And when they overgrow the casing of the garden, they begin to grow into that sturdy, hard bone mineral and replace that sturdy, hard bone with little clusters of myeloma cells, which I penciled in as these little circles in the bone. And the consistency of these cells, these little clusters of cells, they're actually quite soft and gelatinous. They actually have the consistency of raw liver, which is hardly what strong bone is. And so the bone actually gets weakened. On an X-ray, X-rays can't penetrate the calcium of the bone. It's very, very hard. It blocks the X-rays. So on an X-ray, it looks white. But when you replace parts of the bone with these little soft gelatinous clusters of myeloma growth, those don't block X-rays. The X-rays go through. On an X-ray, they look black and round. And so sometimes a provider will refer to them as holes in the bones. These holes can appear in the vertebrae, they can appear in the skull, they can appear in the pelvis because you've got bone marrow in virtually every bone in your body. Now, the problem here is that these gelatinous weaken the bone substantially, and you have to keep in mind that your spine is responsible for maintaining the upward vertical height of your entire body. And so they're all stacked one on top of each other. And so the bottom blocks are under a fair amount of weight stress. And if there's enough myeloma softening them up, you'll actually have them give way. And so those vertebrae, which are normally perfectly rectangular, will collapse. They'll give way and they'll crush. And when they crush, what they do is they cause absolutely exquisite and severe back pain, either between the shoulder blades or in the low back. It's extremely painful and is found in 70% of patients presenting with myeloma. And like any bone fracture, there are very specific characteristics to the pain that you get in your back. Like any bone fracture, if you immobilize and you don't move at all, the pain is relieved. But if you try to move at all with that broken bone, whether it's rotating your spine, twisting, or rolling over in bed, or flexing forward to sit up, get out of a chair, stand from the toilet, that flexion will cause terrible, terrible pain. And since these weeds are growing through all of the bone marrow garden, most patients don't just have one spinal fracture. Many will present with 2, 3, 4, 5 spinal fractures. They're exquisitely painful. For some patients, occasional radiation is used to relieve the pain. More commonly, cement is injected into the bone in an effort to relieve the pain. But the bottom line, it's painful, and it's not the only bone that can be involved. That is a beautiful, beautiful picture of a rib. So that's a rib, and you can see there's a thick outer white hard shell, and inside the rib, clearly there is bone marrow. And what will happen is as these weeds begin to grow into the garden casing, what they'll do is they'll, again, form these clusters of tumor cells in the bone. And I've just drawn that in here as, again, the black dots are the holes. That will weaken the rib at those sites. And so spontaneous rib fractures can occur as well. And not normal. I mean, you get a rib fracture, normally there's trauma. You fell or you've been in a car accident. Myeloma patients can develop rib fractures shutting the car door, coughing or sneezing, rolling in bed. And these rib fractures are terribly painful as well. Take a deep breath, cough, sneeze, next to impossible because the pain is so severe. And this damage, fractures like this, occur in 70% of patients with multiple myeloma. So two of the big things are low blood because the weeds have replaced the garden. Number two is fractures of the bone because the tumor grew into the casing of the garden, weakening the bone. So having said all this, how did your doctor even figure out if you had a bone fracture or you had a low blood count? How did they actually figure out that this turned out to be multiple myeloma? And that goes back to the original function of these weeds, the plasma cells. Remember, these plasma cells make antibody proteins. If there's anyone in the audience who wanted to find out if they were immune to COVID, they asked for a COVID antibody titer. That COVID antibody titer is measuring these antibody proteins produced by plasma cells. One of the reasons that people with myeloma don't always get a great response to the COVID shot is because their production of normal antibody proteins is impaired because they've developed malignancy and the cells are incapable of making normal antibody proteins. What do they make? Well, they continue to make antibody proteins, but they're not functional antibody proteins. So your plasma cells normally, in a normal adult, will make proteins of the 4 flavors: G, A, kappa, and lambda. And what will happen is if the myeloma starts to grow, the weeds start to grow, their production of G, A, kappa, and lambda begin to increase. And they increase very, very substantially. resulting in the finding of abnormal proteins in the blood. And abnormal proteins in the blood is a cardinal feature of this weed growth that we're calling multiple myeloma. And there are a number of different ways to measure the level of the protein. One is by measuring the level of IgG or IgA in the blood. That directly measures the antibody protein. Another antibody protein could be measurement of kappa or lambda. These are actually referred to as free light chains. That's the name of the test that your provider is doing to get some sense of what's going on. And a third technique that is also used is called measurement of the M spike. So those are the three measurements, G or A, kappa or lambda, and the M spike. And 99% of patients with multiple myeloma will have overproduction as the weeds grow in the garden of these proteins, G, A, kappa, lambda. And it is really important for you, if you want to have any control whatsoever on your care, to know your numbers. You need to know your G or your A or your kappa or your lambda or your M spike. Because we use these proteins, the providers, as surrogate measures of how badly the garden is damaged or overrun with weeds. Because the working assumption that we always use is that the amount of protein is directly proportional to the number of weeds in the garden. So what we surmise is that if the protein is stable over time, doesn't change at all, which we commonly see in patients with MGUS or smoldering myeloma, or patients who've previously been treated and are now being monitored in what's called plateau, the protein won't change over time. If, however, the protein is going down, falling, we always infer that that's a good thing, because what's probably happening is we're killing the weeds in the garden. If you kill the weeds, they're not going to be able to make protein. They're dead. And we expect the level of protein to go down. So we expect the lower protein a reflection of killing the weeds in the garden. And the lower the protein, the more weeds have been killed. And ideally, not always achievable, we like to see the protein level actually go down to zero, which we would refer to as a complete response. In any case, that serialized measurement is important. And of course, people who are being monitored and the protein is rising, that's probably bad news, because if the protein's rising, it means that the number of weeds is increasing, the amount of protein they make is increasing. So I want to be sure we're very clear about what the problem is. The problem is weeds in the garden. The problem's not the protein. We're using the protein as a measurement to understand what's going on with those weeds, increasing, decreasing, or unchanged. And we're using the protein as a method to gauge that, so we don't have to do a bone marrow every 2 to 3 months to measure how many weeds in the garden. We're using the protein production as a measurement. But the problem's not the protein. The problem's the weeds. And every single patient produces different amounts of protein. So it's pointless to sit in your support group and start comparing your numbers. My IgA is 2,000, yours is 500, so I'm worse off. That's not true. Everybody makes a different amount of protein. The height of the protein is not critical. What is important is, how does your protein change over time? That's the critical issue. In 85% of patients, the protein has nothing to do with the disease. We use it only as a way to assess the activity of the disease, except for 15%. And 15%, the protein, whether it's G or A or kappa or lambda, has very unusual properties. And in those 15%, it circulates in the blood. And as it circulates in the blood, it filters through the kidneys. And in 15% of myeloma patients, as it filters through the kidneys, the protein actually gels in the kidney. And when it gels, it blocks the flow of urine and ends up damaging the kidney. So 15% of myeloma patients present because of kidney damage due to the abnormal protein. And there's a blood test that doctors use that demonstrate impaired kidney function called the blood creatinine. Some of you may have the blood BUN measured. And by doing that, you get a sense of what your kidney's doing. But again, 85% of patients do not have any kidney impairment at diagnosis. And with effective weed killer treatment, 2/3 of the 15% or 10% normalize their kidney function, so that by time treatment started, only 1 in 20 patients with multiple myeloma have impairment of their kidney function. So let's spend the last 10 minutes talking about first-line treatment for multiple myeloma. And again, easiest way to conceptualize is weeds in the garden. If the weed number is small or the weed number is moderate and you don't have symptoms, that's MGUS, smoldering myeloma, you're living well with the disease, you don't need weed killer, you can be monitored. But patients who develop bone fractures or low blood counts or kidney damage, you need to do something because it's going to get worse if it's left untouched. And so we start with weed killer. And when we initiate therapy for patients who have too many weeds in the garden, there are 5 classes basically of agents that are used to kill the weeds. And so you'll need pencil and paper again. I'm not going to talk about the biochemistry. I'm just going to talk about 5 different classes, because typically what we do is we try to pick different brands of weed killer, because it turns out that if you use 3 or 4 different brands of weed killer, you end up killing more weeds in the long run than by using one weed killer. So the first weed killer that was developed goes back to the early 1960s. And the trade name of this drug is Cytoxan, and the generic name is cyclophosphamide. But what you want is the abbreviation. We refer to that as C or CY. The second class were what we refer to as corticosteroids. That's not important, but it's dexamethasone, which when we refer to it is a D. That's the one that keeps you up at night, changes your mood, makes your spouse angry with you, makes you obstinate and obnoxious. It can cause all kinds of crazy dreams, elevate your blood sugar, demineralize your bones, raise your blood pressure, and increase the risk of infection. But it's a highly effective treatment for multiple myeloma, so it's used. And we refer to that when we do it as D. So now we have C and we have D. The next one that came on the scene is Revlimid or lenalidomide. We abbreviate that as R. That's a pill. Those of you who are taking it usually take it by mouth once a day, 2 weeks out of 3 or 3 weeks out of 4. One of the problems with that medicine is it can cause blood clots. And so people who take the R often have to take either aspirin or a blood thinner, whether that's warfarin or I don't even know what the trade names are for apixaban and rivaroxaban. Dr. Abdallah, what's apixaban and rivaroxaban? You know what their trade names are?
Eliquis, Xarelto.
Thank you, Teresa. Eliquis and Xarelto, I appreciate that, is given along with the Revlimid. The next one that came on the scene was Velcade. That and its cousin carfilzomib, or K, are the 4th brand of weed killer that we combine. The V is more commonly used. That's normally given as a shot under the skin subcutaneously, and it's given once a week. Real careful monitoring, because that V can cause pretty serious numbness or tingling in your feet, not only losing sensation in your feet, but can cause a very unpleasant burning sensation that needs to be monitored for because it will require immediate stopping of the agent if it causes nerve damage. The fifth brand of weed killer on the scene just about 4 years ago, is an antibody called daratumumab, or DARA. Trade name is Darzalex, and we refer to that as DARA, D-A-R-A. So we've really got 5 weed killers, C, R, V, D, and DARA. And when specialists combine them, I would say probably today in the United States, the most common combination used as the first weed killer of choice would be VRD. Some will use VCD, which is also known as Cybord, C-Y-B-O-R-D, but it's VCD. That's another common alternate that's particularly used in hospitalized patients or patients who have impaired kidney function. Some patients in some centers will be treated with KRD, K being the cousin of V. And in many situations, DARA will be combined with DARA VRD or DARA KRD or DARA VCD. But the bottom line, 5 classes of weed killers available. 3 or 4 are normally used to weed kill the garden, get rid of the weeds, let the garden plants grow, and destroy those tumors that are growing into the garden casing. In the last 5 minutes, though, the question is, what do you do after you do 4 to 6 months of that initial 3 medicine therapy with the abbreviations of VRD, VCD, that sort of thing? What is normally done is the patient is normally sent to a large medical center like Kansas, University of Kansas, where they have the facilities to actually take very, very high dose weed killer, I mean big dose weed killer, and douse the garden. And you just pour this stuff over the garden. The idea is to poison and destroy the garden in its entirety so that the garden is killed. In so doing, killing the garden and trying to kill as many of leftover weeds as you simply possibly can. Now, if all you do is douse the garden with weed killer and kill it, the final outcome is going to be mighty bad because you need a garden to survive. You must have a garden to live because the garden's growing your oxygen-carrying hemoglobin. It's carrying the infection-fighting white cells, and the garden's growing the blood-clotting cells. You've got to have those to survive. So in reality, we don't just pour weed killer on the garden. What we do is before we pour the weed killer on, we extract seeds from the garden. We can actually give treatments that will move garden seeds into the bloodstream. And then in the bloodstream, those seeds can be removed from the blood. And once those seeds have been removed, they can be frozen. Now, what we do, now that we have your seeds frozen, is we'll pour weed killer, very high dose, much higher than what you've been receiving with VRD, VCD, DARA, VRD. Pour the weed killer over the entire garden. That will permanently destroy it, but you give it a day or two for the poison to leave your ground soil. We can go to the freezer and extract the seeds that we collected that were frozen. Well, of course, now we're not calling them seeds. We're calling them stem cells now. And then we take those seeds and we replant the garden. And when I say replant, taking those seeds out of the freezer and replanting is transplanting, taking them out of the freezer. And then we grow a new garden from scratch. Now, the problem that makes it not such a simple technique, why you have to be at a large medical center, is that when you poison the garden, that garden's probably completely destroyed by 7 days after. But the problem is when you plant seeds and you need those seeds to grow, germinate, and form new plants and new fruit, that takes about 14 days. So you have a 1 week period of time between day 7 after you plant and day 14 after you plant, where the old garden is dead, but the new garden hasn't grown in, and it gets really, you can get pretty sick because two things are going on. One, you don't have a garden, so all of the garden has to be replaced with transfusions of red blood cells or blood clotting cells. And during that period, there's a very high risk of infection. And that very high risk of infection is one of the major complicating features of replanting the garden seeds or stem cell transplantation. Secondly, the very high dose of therapy that we use causes a lot of injury to the digestive system. Mouth sores, swallowing problems, nausea, vomiting, diarrhea, depending on where the injury to the digestive tract occurs. And when that occurs, then it takes about a week to 10 days for that to heal. People can't eat, people can't drink. It's hard to swallow medications. And oftentimes there's a requirement that you be hospitalized because you can become so ill from that injury to your digestive tract. So I think, Kelly, I've kind of used up my 35 minutes with that introductory comments. And so I don't have any reason why I can't yield the floor back to you so all of us can do 15 minutes of Q&A.
Maury, as always, that was fantastic. Thank you so much. Even been around this for a long time. I always appreciate your explanation of approaches, what myeloma is, and so forth and so on. So what a pleasure. What a pleasure. All right. Going to some questions. Megan, did some questions come up while you were doing this? I see a couple here. Maury, they wanted to know about vision problems.
The most common cause of vision problems, they're very, very common, is dexamethasone. Dexamethasone, which is a corticosteroid, is a medication that really changes the amount of fluid in your eye, and with long use, it can cause cataracts. So while you're on dexamethasone, you can get all kind of refractive problems, and it's a mistake to go get your glasses changed because it'll never work because it's very hard to refract for lenses or spectacles when you're on dexamethasone. Now, like everything else, there's some subtleties. There's a drug called belantamab that can cause eye injury. And of course, if you get cataracts from the steroids, that can affect it. At the end of the day, you do need to go to the eye doctor, but steroid-induced eye problems, you can't see anything. You absolutely, the eye looks structurally normal, but the problem is you can't, what they call refract or accommodate to close up when you're on dexamethasone. It's really common. Normally, I would suggest that you wait it out until you're off dex, and most people are eventually off dex, thank goodness.
Okay. We have a patient here who has stopped treatment, but still is exhausted and feels dizzy and tired. It doesn't say what type of treatment or how long, but it seems like they've stopped and there's some issues. Is that something you deal with, Maury?
So a couple things there is that Revlimid causes a ton of fatigue. It really does. I mean, it can be a real problem and is quite prevalent in the population. And even when you stop Revlimid, it can take a long time for the fatigue to resolve. So sometimes you have to be pretty patient about being sure it's not from the treatment. Dizziness is a bigger problem because there's no test you can do for dizziness. And usually dizziness is due to many, many different factors. Some of the medications have dizziness as a side effect. Some people after a stem cell transplant have problems with their blood pressure when they're standing, and that can cause dizziness or lightheadedness. So at the end of the day, quite frankly, that requires a more thorough evaluation because dizziness, there's a half a dozen different explanations for it. Fatigue, common. Maybe the anemia associated with the multiple myeloma hasn't been fully corrected. Maybe there's still anemia because of the prior therapy, and that's causing fatigue. Again, not one straightforward answer, I'm afraid.
That's okay. Let's see. Should you know all three numbers, IgA, kappa, lambda, and M-spike?
Each patient has their own flavor. So some people have only G or only A or only kappa or only lambda. One thing I would say, which is a common mistake, even though it's prevalent in the literature, I don't, in my practice, follow the light chain ratio because the ratio can be very, very misleading if the uninvolved light chain levels are very, very low. So what I do is I follow the involved light chain, which is either kappa or lambda, and I follow the involved heavy chain, which is either G or A or nothing. You don't have to have a heavy chain. And I follow the involved light chain over time and not so much the ratio. And so, no, you don't need to know all of them, but you do need to know which type of myeloma. When doctors talk to each other, it's very common for them to say IgG kappa myeloma or IgA lambda myeloma so that the providers know which are the relevant proteins that we're going to be monitoring. And if you have, to be blunt, if you have A myeloma, you don't care what the G is. And in my practice, if you have kappa myeloma, I don't care what the lambda is. I just want to know the relevant one that the tumor is making.
Excellent. Following an ASCT, at what intervals should blood testing be done to identify whether M-spike or free light chain ratio is changing?
Well,
During
in my practice,
go ahead.
yeah, thank you, Kelly. After an ASCT, after 100 days, patients are either offered a clinical trial of maintenance treatment, or if they do not wish to participate in research on maintenance therapy, we put them on maintenance. The most common, but not the only maintenance, is Revlimid. And normally I see patients every month where they're on Revlimid. And since Revlimid costs more than a car, I'm measuring their protein levels before I prescribe the Revlimid every month. So I'm checking the proteins every single month, every 28 days, because if the protein rises substantially, I'm thinking the Revlimid's not working, and I'm not going to prescribe $16,000 worth of medicine for you to throw away because it's not working anymore. So I'm getting monthly assessments in patients on maintenance. Now, there are some patients who are not on any form of maintenance, or they have smoldering disease or MGUS. That is a judgment call based on what you know about the protein over time. But as a rough estimate, in a smoldering myeloma patient, I'll check every 3 months, but that's not set in stone. You know, if it's rising, more often. If it's not rising, less often.
Okay. Well, you got a compliment here. Really like the garden analogy. Makes so much more sense than I was thinking about my disease.
Yeah, I just made that analogy up about a week ago.
Yeah, they just love it. Now, how important is dexamethasone while on DAR or Pomalyst?
It depends on what phase. For initial therapy, dexamethasone is important. I mean, if you just took dexamethasone alone, 50% of myeloma patients who get dex only will have a 50% reduction in their proteins. So it's highly active. I do think that in general, not enough attention is given to customizing the dose for the specific patient. I think older patients, or more frail patients, the usual 10 pills once a week is way too much. And frequently in patients who've had a good response, I start scaling the dexamethasone back quickly because it really affects quality of life. Most patients despise the drug. And so I'll go 10 to 5 to 3, and I'll try to get people off dexamethasone before 1 year is out, because it really is, it's just not tolerable long-term. It makes people nuts. And then they make everyone else nuts.
Okay. I've been around those people. I agree with what you're saying. Revlimid caused a horrible full body rash for my husband. The doctor lowered the dose to 15 milligrams. Does higher milligram dosage mean more effective treatment, or should we be concerned with only having 15 milligrams?
So first of all, the doctor was obviously very bright, because there are some doctors who get the total body rash and will abandon the Revlimid. This doctor was clever, because Revlimid is such an important drug, you don't want to abandon it. And so there are options. Give it at a lower dose, or not give it for 14 or 21 days, but shorter periods of time. Some people get a rash, get re-exposed, nothing happens. Some people can be sent to an allergist, and the allergist can desensitize you to Revlimid. You don't want to give up on Revlimid. You don't want to give up on Revlimid. That is too valuable an anti-myeloma drug. And so kudos to the doctor for sticking with the Revlimid. Now, is 15 worse than 25? The reality is no one really knows that for sure, because the way we develop anti-cancer drugs is we give it until people can't tolerate it very well. What we seek out in our trials is the maximal tolerated dose. That's usually for cancer drugs what we try to figure out. But maximum tolerated dose may not be the correct endpoint. I mean, it maybe gives the highest likelihood of benefit, but what we really want is the minimum effective dose. And there are no studies to suggest that 15 is inferior to 25. So what I would say to this patient is be very happy you're still on Revlimid, and I think it's 100% fine that you're on 15 milligrams. I wouldn't feel too bad about that at all.
We have several questions about diet and homeopathic treatment to a successful outcome of myeloma. Can you cover a couple of those questions?
Yeah, this is a pretty volatile, because people get really, really committed to their supplements and their curcumin and their antioxidants and their low sugar diet. But if you've got weeds in your garden, that's the problem. Weeds are growing in your garden, and these weeds are genetically abnormal. The reason they're cancer is because they've developed genetic abnormalities. And we measure that when we collect your garden weeds on a bone marrow sample by looking at what's called FISH, because it shows what genes have been mutated and are abnormal. I do not know how your diet or supplements are going to do anything about those weeds. Now, obviously, diet's important because you want a healthful diet, because if you're healthy and you're not obese and you have a normal lean body mass index, that's going to help you tolerate treatment. People who are fit, have healthy hearts, no high blood pressure, non-diabetic, usually weather the side effects of treatment better. They certainly do better with stem cell transplantation because they're more fit. So it's really a question of fitness. And of course, fitness is in some part driven by healthy diet and healthy exercise. If you did a poll of doctors to find out what fraction take supplements compared to the general population, I suspect you'd be in for quite the shock about that. But in terms of diet, it's the healthful diet, the same diet you would for cardiovascular fitness, and supplements are essentially unproven. And there's just no proof of their beneficial impact in multiple myeloma, including curcumin. And Teresa, what's the other one that people take?
Well, there's green tea, there's vitamin C, there's actually quite a few. Turmeric is another
Turmeric
one.
is the one I was thinking of. That's a very popular one. Thank you. But everything you said is legitimate. And if you look in the scientific literature, and just Google it, and look for not advertisements from General Nutrition Center, but look for scientific articles, you're not finding it. There hasn't been anything published on turmeric and the other one for 15 years. And even that was just tested myeloma, not patients.
Oh, great. Here's a question from someone that might have missed something. He says, is it possible for myeloma to affect both kappa and lambda where a person has MM kappa lambda? Same question for G and A. Sorry, I might have missed it.
No, you didn't miss it. It's a complicated question. There's two possibilities. 3% of myeloma patients have what's called biclonal disease. It's not very common, so I didn't mention it, but they have actually a G and an A, or a kappa and a lambda. And you have two clones, one of which is normally dominant and one of which is not. And it's actually too complicated for this venue but it goes to your specialist to figure out which one is the important one for the myeloma. Having said that, about 5% of myeloma patients will have elevations of both the kappa and the lambda, and one of them will be the involved myeloma protein, the other will be the uninvolved myeloma protein. And again, it's up to the provider to tell you which is the one that's important. But some people do have unexplained elevations of both, even though one of them has nothing whatsoever to do with the multiple myeloma.
Excellent. Again, you went over the stem cell replacement. Are there other options that are gaining traction in your practice or those of your peers that should be given serious consideration?
There will be a presentation of a randomized trial in 2 weeks at the American Society of Clinical Oncology that will define exactly where stem cell transplant belongs. But today, in my opinion, this is my opinion, transplant is the global standard of care for those patients in whom it can be done safely. And it's clearly been shown to deepen the response, increase the fraction of patients who are MRD negative, and improve the progression-free survival, which is another way of saying the time you have without myeloma. So in my opinion, people who decline a stem cell transplant, bluntly, I think they've done themselves a disservice because it's such a highly effective treatment. But no denying, it's a toxic treatment. And people get chemo brain, a very real syndrome, where cognitive ability is impacted and people have trouble with concentration, short-term memory, and actually this can last up to a year. A very real problem, and it does affect one's quality of life, not so much personality change beyond the fatigue itself and the recovery of nutrition, but it's a very real complication. And again, I met many patients who've declined stem cell transplant, which I think by and large is to their detriment.
Okay, well, the last question, does a stem cell transplant cause changes in the patient's brain activity? Is that what you were just referencing?
Yeah, that's the chemo brain. I mean, it really does. I mean, I've transplanted quite a few physicians. I've cared for quite a few physicians with multiple myeloma. And these are very reliable people, and they confirm over and over that there's real change in your memory, thinking, cognition, that sort of thing. And so it's a very real phenomenon that does have to be contended with when considering stem cell transplant.
I want to squeeze this.
Can I go meditate now?
One more question, then you get to meditate.
All right, last one.
All right, my husband is 5 years out from his treatment. The numbers are beginning to climb. He has more stem cells in storage. Is a second transplant generally a possibility?
So it's a possibility, but that shouldn't be answered that's not educational.
Okay.
That's a second opinion. You really need to sit down and talk. 5 years response to transplant does make a second transplant a possibility, but it would be a mistake to generalize about what you're going to do. How to manage first progression really is Dr. Abdullah's job in the next talk, and he'll discuss some of the options, but I would certainly say it's a possibility, but a lot of it depends on, was the first transplant really easy? Was it a cakewalk, no hospitalization? Was it very complicated? Did you get very sick? What other options do you have in terms of management? What clinical trials are available to you? And so in general, the answer is a possibility, but there are, as you're going to find out at 11:05, there are a lot of options available to you.
Bravo, Maury. That was a lot of questions you handled, and everyone loves your weed concept. It just makes people understand a lot about myeloma. So I'm very grateful for you to take your time on Saturday. And now, everyone, let's go into a little relaxation, coffee, meditation, go to the restroom, whatever it takes. We'll see you very soon. How was that so far? We got a lot of information about the disease from Dr. Gertz and a lot of drawings. I think he did the best drawing. God, I couldn't say that. The backbone drawing about myeloma that I've ever seen. But now We have relaxed therapy and clinical trials with Dr. Ala Abdullah, who represents University of Kansas Medical Center. And are you set with your slides and ready to go?
Okay.
Thanks, Doctor.
Thank you very much. And thank you very much, Kelly, for inviting me. And also thank you, Dr. Gertz, for this outstanding lecture about newly diagnosed myeloma. And today I'm going to talk about relapse, therapy for relapse myeloma and clinical trials. Let's see if I advance. Okay. I know everybody's seeing my first slide, so I always like to start that I really don't have any financial relationships to disclose. So I like to start with the first slide here, and this is kind of, in my opinion, the most important slide ever. My mentor, Dr. Ganguly, actually taught me about one important thing if I want to learn about is that randomized clinical trials in myeloma is very important and critical. Reminding us about this trial, although it was done back in 1966, and I still kind of hold it in any presentation I do, is that they compare in myeloma patients who got chemotherapy at that time that was in some institutions considered as standard of care called urethane, with a response for these patients. And patients even had, a benefit from this treatment, and they compare it as, a cherry or a cola flavored, like a Coca-Cola, and believe it or not, at that time, there was actually a survival, there was a decreased survival in those who got urethane and a higher death rate. Why exactly this is very important? Because it reminds us every single time, and unfortunately, because especially now, and we really need to remind ourselves, why do we treat myeloma? Do we treat to make the numbers better, or do we treat to make the patient feel better? And I think that's the most important concept that we're missing here. In my opinion, after all I actually spend good time in University of Arkansas and here at KU, I understand that two things we really need to actually measure. Quality of life of the patient is very important, and the treatment is supposed to make the patient feel better. And number two, survive longer. So these two things are very important in any treatment that you want to choose in myeloma. And that's where I actually kind of measure these two things. If I feel the treatment is harming the patients or there's no benefit of survival, then I really try to look for some other treatments, because we do have a lot of options, but we need to choose the right one that we believe are good for the patient. So always it's not the number that we really treat. It's to improve the quality of life and also the survival. So relapse myeloma, as much as I hate to actually give this lecture, because I like always to see patients stay in remission as long as possible, but unfortunately, it's a common thing that we see it in myeloma. Unfortunately, most of the patients relapse, at least 85%. 10 to 15% may stay in remission for the rest of their life, and that's kind of like what we have roughly understand about that. The problem is not about the relapse, the problem about the course of the relapse. It's very easy to get the patient in remission and early diagnosis. The patient's myeloma is naive. As Dr. Mori has said, like steroids itself, if you get it as a single agent, you can drop the myeloma numbers by 50% of the time. And that's really a reality. But the problem here is that every time you relapse, it's like a newer disease, a more aggressive disease come there, and it's more difficult to get these patients in remission and more difficult to respond to the treatment. And not only like that, the shorter they stay in remission. Every time these patients relapse, it becomes more and more complicated. So what happened here is that we always try to kind of alternate and try to find a newer agent or a newer class that the patient never got exposed to have a higher chance that the patient stay in remission. Now, there are types of relapse, and this is kind of an old chart. And what I will actually like to talk about, how do we define relapse myeloma? And there's different types. The commonest type I really actually seeing more is the incidence, although it's like saying 18%, but the incidence form is that the free light chain, the paraprotein levels are going up. And based on the IMWG, which is the International Myeloma Working Group, they actually kind of identify some numbers that if the paraprotein and the free light chain continues to increase, this is an indication that the patient more likely will have the classical relapse, which is a bone fracture or a bone lesions, newer bone lesions, plasmacytoma, or kidney failure, or bone marrow failure, which is anemia. So we try to kind of advance ourselves and prevent this to happen. Of course, classical form, I'm not seeing it very often because we're catching it through close follow-up of these patients with myeloma. Plasmacytoma, which is soft tissue masses, extramedullary disease, is my one of the nightmares that I don't like to deal with is especially if the central nervous system is involved. And the worst of all of that is secondary plasma cell leukemia. Although rare, but it can happen. It's just presence of some plasma cells, and at least 5%, and some people define it still 20% of the plasma cells in the blood. These kind of forms are forms of relapse myeloma that require the physician have to interfere in that regard and treat these patients. So before we talk about what type of treatments we like to use, it's not really easy. It's not like an ABC, like, you have all these therapies, which one you prefer. Really, there are a lot of factors that really depend on. It's really depend on the disease, what type of treatment the patient got. And I don't always forget that patient also have the right to choose. They have a preference. There's social factors that plays a role. Comorbidities, like the patient have heart failure, or he have renal failure on dialysis. There's a lot of factors that really contribute to actually make your judgment how to choose a treatment. So it's really not an easy way to say it. So a patient, let's say, got a drug like Revlimid and have very bad toxicity from that, and he didn't tolerate it well, or have Velcade and have bad neuropathy, and the neuropathy is still there. I mean, there's a lot of question about re-challenge these patients with the same treatment, and he have a bad toxicity. So we try to kind of evaluate how bad was the toxicity, and if the patient can tolerate it or not. Of course, we have a lot of options of therapy for relapsed myeloma, and every time we have a class, it's not like a single agent that we use. Like we have immune modulatory drugs that in the old days was thalidomide, but commonly we use Revlimid and pomalidomide. We have proteasome inhibitors. Commonly, the two drugs that we really use is pertuzumab and carfilzomib. Less likely now ixazomib is used, although it was supposed to be kind of like an additional treatment for myeloma patients. Dexamethasone is still there, even in relapsed myeloma. Monoclonal antibodies, the commonest CD38 that's more effective, whether it's daratumumab or isatuximab, and there's another form of elotuzumab that also rarely we're using it now. And there are generations. I think there was a third one like selinexor, belantamab, and melflufen that was removed recently. And now we have the CAR T cells, which is BCMA targeted therapy. And that's going to be a very heated subject today that we're going to talk about it. But as much as I say, it's not single agent that now we are using. Most likely either it's doublet, 2 drugs or 3 drugs. The more you give these drugs, the more you have a capability to kill more myeloma cells. And that's exactly what we realize. And every combination therapy, you can see more and more of these combination therapy. And we have a lot of options. Now, for once, you might see that more options, that is great. That's perfect. That is what we really need. But reality is this. We really have a traffic at the first relapse. We don't know which one it's better to use because you have all these myeloma treatments, and we're assuming that all of them are great. All of them are better than each other. But as I say, if we go back to the slide that I talked about, there are a lot of factors that really actually determine that. One of the major factors, in my opinion, and I actually look at it as first, is that what was the last treatment the patient, relapsed on? If a patient relapsed on Revlimid, does it make any sense to restart the patient on Revlimid? And I know a lot of argument between if it's the low dose, you can increase the dose. But a lot of common sense here is that which option you would like to treat these patients. So, I'm not going to talk a lot about these slides, but it's just like to show you how many options we have and what exactly we look at. First, if the patient got if the patient is not refractory to Revlimid, there have been a lot of studies that compare 3 drugs versus 2 drugs. And combination with Revlimid Dex was successful in many treatments like daratumumab, which I will talk about that, ixazomib, which is another form of proteasome inhibitors, carfilzomib Revlimid Dex, and elotuzumab Revlimid Dex. And all of them has shown a benefit of using these 3 drugs in comparing to just only 2 drugs. But most commonly, I see those patients who got Revlimid. Most of my patients, I put them on maintenance Revlimid therapy. So I really try to kind of use other options with that, with a proteasome inhibitors as a combination, whether it's dara carfilzomib Dex or dara Velcade Dex or ixazomib, isatuximab carfilzomib Dex. And there's other options I don't commonly use except in certain situation like carfilzomib with the old treatment Cytoxan, and sometimes, which I'm going to stop actually using the carfilzomib dexamethasone because it has been shown it's inferior based on the newer trials from the CANDOR and the IKEMA trial. And there's other triplet therapy that also are available, and it's also great to use. The isatuximab, elotuzumab, and darapomdix. All of these are great to use, but that's still a problematic. Exactly how do we actually utilize it? How do we use it? There's all these drugs have benefit and have risk, and the problem here is that, as all of you can see, all these treatments have been compared 3 versus 2 drugs, but we never seen that 3 versus 3 drugs. Now, currently, there have been some trials that they're trying to compare 3 versus 3 drugs, and to give us a little bit insight which one is better for our myeloma patient. But to identify the best option here is that I kind of like, and my colleagues here at KU, we review all options of therapy. And to be honest with you, we found out, I know I kind of like put all the slides for progression-free survival for 2 drugs, the CD38, whether daratumumab or isatuximab. And we found out that 2 great things we have. All the trials have shown there is a benefit of these, adding the daratumumab or isatuximab to any doublet therapy. And when I say any doublet therapy, whether it's a immunomodulatory drug like Revlimid or pomalidomide, or proteasome inhibitors like Velcade or carfilzomib, or and that's really important thing. These 6 trials kind of like showing exactly that benefit of adding CD38. For our standpoint, if the patient never got exposed or never progressed on a CD38, it makes a lot of sense to use that regimen, a daratumumab-based therapy. Now, which combination you're going to use, it really depends, again, about the tolerance, the side effects the patient had. It depends on the availability. It depends on the patient preference. I have patients, for example, and it makes a lot of sense. They don't like to come to the clinic very often. So, honest opinion, most of the patients who don't like to come to the clinic, I use the combination Dara-Pom-Dix, And the reason I use Dara over isatuximab, it's not about preference, it's about common sense, because the patient himself, eventually after 6 months, if he stays in remission, the drug is going to be given once a month, and it's a sub-Q, an injection that they get it in and out, and he's going to get another pill. So more likely the patient will be more satisfied with this type, So it's more about convenience for the patient, and which I believe it's better, that we actually follow and try to treat the patient based on what he prefer. Of course, every time we have a newer drug, there's one problem that we face. We consider ourselves, we're actually opening more and more options. But the problem is not here. The problem is that drugs like daratumumab, we see it's really beneficial in relapse myeloma. So what happened here is that we take that drug and we move it up front in earlier diagnosis. And what's the biggest problem here? Well, the problem here is that, unfortunately, with that situation, we are not knowing exactly if the patient exposed or have refractory to daratumumab, what we would do. We have great trials that actually showed benefit of daratumumab-based therapy on those who never got daratumumab at the beginning. But we don't know exactly what will happen to them if they got exposed. We don't know even the other trials, although they were really great. Most of these trials, they never actually were tested in those who are refractory to daratumumab or relapse of daratumumab. But again, every time there's a new class, we also kind of see newer classification of myeloma. My classification of myeloma for late relapse, I know we have a lot of people who talk about lines of therapy, but more important than lines of therapy is that what exactly are they refractory to? I see that this is the best kind of the best way to classify how aggressive the myeloma is. And I know we use high-risk myeloma, but if the patient is what we call triple class and pentaclass refractory, I think that's really significant. And as I say, there's with the exception of transplant, when you give it to the patient, there are 3 class of myeloma, 3 class of therapies that I actually consider are high likely patients must be used before you kind of give up on a patient. Immune modulatory drugs with their Revlimid and pomalidomide, proteasome inhibitors, Velcade and carfilzomib, and monoclonal CD38 antibodies, which is either daratumumab or isatuximab. If you're progressing on any of these, on 3 of the drugs from each class, that's a triple class refractory. If you progress on 5 of these drugs, that's penta refractory. And although this is a retrospective study, it's not a best study, we know that they do poorly if they actually are refractory to these drugs. We know that the survival for those who are only refractory to 3 of these drugs have about 9 months survival. And those who are 5 of these drugs, the survival is 5 months. So the biggest question have been always asked is that what options we can actually use for these patients. Let's see. Next. Next slide. Okay, so the good thing is that FDA has approved several treatments for triple class refractory myeloma, but there's one thing in common for these, and I just want to inform a lot of patients about that because I know there's a lot of argument which one is better. These treatments are approved based on phase 2 studies, not phase 3 trials, which is none of them are randomized trials in order to see which one is better. So the first one was selinexor. I'm not going to spend a lot of time about the mechanism of action or that, but the main thing was behind the approval of that was the STORM study. The STORM study actually took those patients who were triple refractory myeloma, heavily treated, and they actually evaluate 26% of these patients who received selinexor with dexamethasone. 26% was the response rate. However, the median survival was about 8 months. The progression-free survival was around 3.7 months. The problem I have critiques about the study itself, it's not only, it doesn't give us a clue exactly if this is going to benefit the patient in terms of surviving longer, but, it was actually because the trial itself has a combination of dex and selinexor. Earlier studies was questionable about selinexor as a monotherapy, and it shows a response rate of 4%. So we're not exactly sure how effective it is adding selinexor to dexamethasone and comparing to other drugs. But the side effects and toxicity is a lot of questionable. The GI toxicity, the hematological toxicity, that makes us a little bit concerned about how effective it is and what kind of side effects that we can actually use in that regard. The second drug that got FDA approved is called belantamab. And carefully, I want you to understand that it's an IgG anti-BCMA, and BCMA is something you have to memorize because that's going to be a very big thing in the future, and it's coming very fast, and widely spread in all earlier and late relapse. And I'm expecting that this is also going to be used more like the newly diagnosed myeloma in a lot of clinical trial. BCMA stands for B-cell maturation antigen, and that's present in 95% of myeloma cells. If you kind of suppress that, you have a higher chance to stop the myeloma to grow and to stop it from proliferation. But the treatment here that the belantamab is using, it attaches to this toxin chemotherapy we call MAF or MMAF, the monomethyl auristatin F. And when the antibody actually attach to the BCMA, it internalize and put that chemotherapy inside the myeloma and causes death and destruction for the myeloma. That's the mechanism of action for it. There's other mechanisms of action associated with it, but that's the main one that works on this type of disease or type of relapse myeloma. And what happened here is that most of these patients who have in the DREAM-1 study, it showed actually that they have a response rate over 60%. But these patients were kind of generally. When they did the DREAM-2 study, actually, they involved only triple class refractory. The response rate was around 31%. I kind of summarize all of this just to show a lot of patients the type of treatments that was approved. Only one of these drugs, which is mifulfendex, and I'm not going to discuss a lot about it because it was withdrawn from the FDA due to concern of safety. The two drugs that approved, selinexor, dexamethasone, is the first part, showed a response rate 26% in these group of patients. The belantamab as a single agent was 31%. The progression-free survival was between 3 to 3.7 months. And unfortunately, the toxicity is very important to as well, especially with selinexor causing GI toxicity, hematological, lowering blood white cells and platelets. The belantamab, which is from the DREAM-2 study, they have a weird toxicity of eye toxicity, keratopathy, which is like their eye vision, blurry visions. They have a cornea effect that they have to require to see an eye doctor before each treatment. And the percentage is really very high. At least 75% to 80% of the patients who will get the treatment will have the eye toxicity. Very commonly, the delay of the treatment and also dose reduction happen because of the keratopathy. But if you actually ask me, is that something when you discuss with patients, they're really thrilled and happy because they have an option of therapy? Just imagine yourself sitting in front of a patient telling them about the response rate and the median progression-free survival, and you're talking about the survival benefit, we don't know it because we really don't have a good randomized trial. And then you mentioned the side effects in a different way. I don't think I have ever seen any patient thrilled about that. But do we have options here? Well, 5 years ago, I was like impressed about CAR T-cell, and I was seeing some great results. And I was saying like, this clinical trials have to be open here at KU, and we have to give these patients CAR T-cell, not because the effectiveness alone, but also because quality of life. You give a treatment for CAR T-cell for one time, and they're actually, if they go to remission, they have freedom from coming to your clinic and doing anything. So I think that this was one of the things that I was actually rooting for, CAR T-cell for these patients. But what is CAR T-cell? Chimeric antigen receptor T-cells, an immunotherapy treatment. It's your own therapy that your own body attacking the myeloma cells. But how is that? We take your own T cells through an apheresis, through blood, extraction from that, and we send it to the pharma company, which actually two of the pharma companies that actually work on getting these T cells engineered. And as what they do is that they actually insert a gene in order to produce, I would say, what we call a laser tag. A laser tag. That is called chimeric antigen receptor. Now, when I say that in general, that's what they do. They have to find out a target. Now, in acute leukemia and lymphoma, they have a different target. In myeloma, we have a target, and we talked about that. The BCMA, very juicy target. It's present in 95%. So they build that laser tag to attack the BCMA. So after they do that, they make millions and millions of these cells, and then they ship it back to the institute. And what we do is that we give a small dose of chemotherapy to kill all the lymphocytes in your, most of the lymphocyte in your body, and then so that it doesn't interfere with the CAR T cell, and infuse these CAR T cells that are modified. And once it goes here in your body, it tries to find the BCMA myeloma, attach to it, and gather all the CAR Ts and start shooting on it the cytokines. The cytokines are like bullets that go kill the myeloma cells and destroy. Now, that's the mechanism of action. But is it effective? I believe in something. I like to learn about the mechanism of action, but honest opinion, I like to understand, does it reflect what we really see? Because I heard a lot of mechanism of action that really beautifully designed, but in real world, it becomes disastrous. So I look at the studies like that was produced. Now, I don't like to compare apples to oranges. So I don't want people to, what about like comparing it to the DREAM studies and the selinexor and all this stuff? I like to look exactly at what we really have. This is a single arm. They never compare to each other. And what they actually use different dosages of the CAR T cell or number of cells. Totally, for all these patients, the response rate was 73%. But if you look at those who have the higher dose of the CAR T cell, the response rate went up to 81%. 40% of these patients went to complete remission. And all these patients were actually were heavily treated and triple refractory, which is a very good sense that this is a better result. I mean, it makes more sense to, when you tell a person you have an 80% chance that you respond to treatment, or 70, 80% versus 30%. So you can see exactly how the conversation between a myeloma doctor versus a patient can actually make a lot of sense. So what happened here is that we know exactly what is the reflection about the remission versus non-remission. Most of the patients in general who got this treatment, the progression-free survival was about 9 months. Not very impressive, but those who got the higher dose, they stayed in remission for about 12 months. When we look exactly at the real actuality, that we saw that the patients who got complete remission, they stayed in remission, they didn't have progression disease for 19 months. And that's really also impressive in this population of patients who have refractory disease. But the survival in general, and again, this is single arm, showed in 19 months overall survival. And again, I don't like to compare it to what we have, but as we talked about that in those who are triple refractory and penta-refractory, the survival is between 5 to 9 months. So it's very difficult to make this comparison, and we don't like to compare like this clinical trial with the real world, what we see. And we're hoping that we'll have more comparison. But we really actually see a lot of benefit of using this CAR T cell. But it doesn't come for free. It comes with some safety issues. And a lot of patients, the first thing that we actually, I would like patients to understand, one of the major things that we get scared about that is weird things like word cytokine release syndrome or neurotoxicity. And the reason of that may be because we're not used to that. But reality is that, the cytokine release syndrome for a lot of patients is like grades. There's a very mild grade that patients will have fever, chills, and it can be worse, like shortness of breath, chest pain, and lower blood pressure, and patients can be intubated. We really don't see that much, and we have a drug called tocilizumab that will antagonize one of the cytokines and decrease the incidence of severity in these patients. And neurotoxicity is not really that common. Even the higher grade is not common, because I believe the benefit of the treatment outweighed the risk, especially in this level of myeloma progressing, and there's really less options for the patients. And usually these patients will present with some confusion, worst scenario seizures, or brain edema. But honest opinion, something I was actually surprised we ignore the fact that there's other common side effects. And actually, although we don't believe it's nightmare for the hematologist because we're used to it, but it really actually, and this is one thing I want patients to understand. It really actually kind of like redefine our purpose of doing CAR T cell. The purpose is to provide a better quality of life. And when we see their white counts, their blood levels, platelets are low, and some of these patients require to be admitted to, or they have to come once or twice a week for transfusion, it doesn't make any sense, because the whole purpose of these patients to stay out of the clinic, and enjoy more of the time with their family. They're higher risk for infection coming from the fact, unfortunately, because of the immune system, or the immunoglobulin dropped down very low, and they're really high risk for these infections. So I don't know exactly if the theory is behind that, because these patients have received many lines of therapy and they got exposed, and you're giving them a treatment that can cause this, and that's why they have a longer cytopenia, what we call it, like lower counts. And maybe if they are moved a little bit upfront in earlier relapse, that will not happen. So we're hoping to see that will also be removed, because I think that will improve the quality of life more in the future. Now, that trial actually got the CAR T cell approved last year, and now we have another trial that also recently, I think a few months ago, that got approved, the CARTITUDE-1, which used another drug, Cell. This drug actually showed a response rate of 97%. About over 82% of these patients got a very deep, complete remission. In the 2 years, we don't have a median progression-free survival, but the 2-year progression-free survival was about 61%. And that led kind of like why we actually choose to actually approve, this was approved by the FDA as also a second CAR T cell. The same side effects, I kind of like see it. Cytopenia, the cytokine release syndrome, and the neurotoxicity, in the same way that we treat these patients in order to prevent kind of any further toxicity. So as much as we say that these two CAR T cells were available, we are always excited. And as I say, I was like, every patient after the CAR T got available have and must receive CAR T cell, because it kind of like have not, and forget about the response rate, because you have to make a comparison between the CAR T cell and the other treatments. But the quality of life is amazing. You give one patient a treatment. Every myeloma patients, especially those who got treatment for about 10 years, most of them, I always try to give them holidays, especially in their remission. They really need like a big break, especially now. Like, imagine you just give them one treatment and they stay in remission for a year without any treatment. Many of my patients, when they get the CAR T cell and they went to remission, they were actually out in vacation in Florida and a lot of places. It kind of like was the first time they're really enjoying their life. And that's the whole purpose of giving CAR T cell in these patients. But this is the reality, and it's sad that really we don't have enough slots. And I don't know exactly what happened here. And as much we tried to talk to the companies that produces that, if you're in a big myeloma institute, you have many patients that need CAR T cell immediately. And if you're in that race with triple and penta refractory, their myeloma doesn't wait for a month or 2 months to actually progress. Their myeloma really progress in a matter of weeks. Every day count against you. So when you have one slot instead of like 3, if you ask, I want 3 immediately. I mean, 3 is if you're generous. You really have to think out of the box. Who's the sickest one? Who's going to benefit? Who's that? So you're making really bad sacrification about that. And these decisions, we really feel very, we as physicians, like it's really heart feeling, because we want all our patients to stay in remission, have a better quality of life. And we hate to kind of like give one slot to a patient and other 4 or 5 patients, actually need that as well. So I think we need better options. Hopefully in the future we'll have that. So gladly, other trials are actually built up, like the bispecific T-cell engagers. It's a different form of immunotherapy. And what they do is that instead of taking your own T cells and micromanage it, putting that laser tag that I talked about, that they give you an antibody that have two arms. One arm goes to the BCMA, remember that BCMA that is in myeloma attached to it, and one arm goes to the CD3 on the T cells. So instead of taking that T cell out, engineer it, say, well, I'll put an antibody and it will attach the T cells and make it close to the myeloma cells and produce the same amount, the cytokine, and attack the myeloma the same way. So it makes what we call like the off the shelf. So it's there. I don't have to worry about manufacturing. I don't have to worry about when the cell is going to come back. I just give the treatment there. Unfortunately, it's still a clinical trial, so it's not available yet, but I highly think that it's going to be hopefully available soon commercially for a lot of myeloma patients. And the reason, and again, this is as a single arm. This is not randomized trial, so we have to remember that there's a lot of options of this type of treatment. Tislelizumab is one of them that happened to be there. And I look at all the patients that got in that study, most of them triple refractory. The response rate is 62%. And the complete remission for that is about 1/3 of these patients who actually got in complete remission. It's making more sense to hopefully use it like if as an alternative if CAR T cell is not available in these patients. Regarding the toxicity, it's kind of like similar to that, although people will compare it to the CAR T cell. I don't like to compare it to CAR T cell for one reason. There's no head-to-head to compare it and see if they really cause more cytokine release syndrome or less. But they definitely cause a lot of cytopenia in that case. Maybe it's not as as aggressive, but it can also increase risk of infection in these myeloma patients. Talking about what is the commonest question I receive from patients, especially I have trials for BiTE and CAR T cell. The commonest question, which one you think is better? And, honest opinion, as much as maybe it looks like the same, maybe the results are impressive in one over the other one, the only way to know it, if I bring a BiTE and a CAR T cell and put him head to head to compare it, that's the only way. But I would like to be very honest. Why do I choose one over the other one? So let's say I have a patient and I have the BiTE in front of my hand and a CAR T cell. And I can give that patient CAR T cell immediately, or it takes 4 weeks and I guarantee the patient will get it. I'll give them CAR T cell. The reason is not about that there is a question about response rate or anything like that. It's the first thing when I talked about quality of life. The BiTE, unfortunately, you have to come every week for getting the treatment. While the CAR T cell, you just give it one time, and if the patient goes to remission, you can identify exactly how often the patient can come and get lab tests. But most of the time, these patients don't have to come weekly or twice a week, to get any treatment or get any labs or office visits. And that's why I really aim for. The reason I give CAR T cell for these patients is a better quality of life, spending very good quality of time with their loved one, and also enjoying their life as they were supposed to go vacations. I don't have to worry about a patient saying, I'm going to go CAR T cell, I have a colonoscopy, do I stop the treatment? Or I have an eye cataract surgery, when to stop the treatment and how to do that, or something like that. These things, I don't get worried about that with a CAR T cell patients versus like treatments that you have to make sure the patient's getting treatment and you have to delay it and you have to schedule it. So you can see the difference, a better quality of life for the patients. So the reason I choose CAR T cell over BiTE, and although BiTE is not available, but if it will be available, is the better quality of life. That's the answer. I always answer the patients for that. And as much as says that we have a lot of options of therapy, we call these options. And every time you have an option, unfortunately, some people actually think it is as an open buffet, that you can choose whatever you want. And you can actually determine which one is better for the patient. But reality is this. It's really catastrophe. Every time we have a newer drug, we really need to know exactly where we are going to put this drug, where exactly we're going to actually benefit this treatment more. CAR T cell is effective, but we need randomized trials. So I can know exactly, is it better than a triplet therapy or not? Is it equal to a triplet therapy? Is it worse than a triplet therapy? Where exactly can I put it? This is the problem that we're really facing. And I think that's where I put my kind of like the clinical trials. I know I'm supposed to talk about it, but one of the reasons we have all these problems is that the clinical trials are avoiding the real answer that we really need. Which one is better? I don't want you to add 27 or 28 drugs and tell me that I need to give a patient 20 lines of therapy so I can make myself look like I'm trying to make the patient survive. I want to give a patient less lines of therapy and live longer. That's the whole purpose. If I feel the drug, one of the drugs is not useful and it's not being utilized well, then it should not be actually in the NCCN guidelines or anything like that. We have to, as I will say the word, clean the drugs and make sure that we have the right treatments, the most effective, the less side effects that can provide the two major things that what we want to provide patients: better quality of life and longer survival. That's the whole purpose of the clinical trials. Now we're seeing a little bit better improvement and more randomized trials coming back again. And that's one thing that we're hoping that we'll see in the future. Now, last, I want to say my conclusions are that DARA, isatuximab, or any CD38, which I think these are in my opinion, it's an early relapse, especially for those who never got that, is considered the optimal choice. And it depends on your own oncologist. I do not actually tell which one is better. It depends what they feel is better, depends on patient preference and many factors. Of course, there's a lot of, say the word choose wisely, especially on patients who got prior lines of therapy, proteasome inhibitors and immune modulatory refractory. One of the advices I tell my oncology colleagues, please go and review what previous treatment these patients got. Were they only exposed to it, or they have refractory to disease with it? Unfortunately, some of the patients are saying they got exposed, but they never relapse on that treatment. And that's a very important thing, because it can give me a chance to give you this treatment in the future and have a better benefit for that. Main challenges, in my opinion, still the triple and penta refractory, and we still need more randomized trial in that group, and because we don't know exactly which one is better. We're just based on our own judgment and our view that why are we preferring BCMA targeted therapy, especially CAR T cell. Of course, we have 2 CAR T cell now approved for triple class refractory. The reason, again, I still say this word is better quality of life. That's the reason why I choose it over other treatments. And I believe this is for the future. I think this is going to be approved, in the future. The BCMA B cell maturation BiTE, how is that going to improve things? Well, in my opinion, I think it's going to be off the shelf, and hopefully the slide availability and CAR T will be more available for patients. But if that's not happening, I still believe that BCMA is a very major and an important factor, and it's going to be added really strongly to the other 3 drugs classes, the immune modulatory drug, proteasome inhibitor, and CD38 in the future. And we really actually now, we're talking about this. We talked about triple and penta class refractory. We're going to start seeing a new era of new myeloma who are BCMA failure after CAR T or BiTE. And honest opinion, we are always speculating after that. We have case reports, we have small retrospective studies, but in other words, and I want to be very, very nice about saying that, we don't know what we're doing after that. We don't have a clue exactly what is the best treatment after that. So we need more trials after the BCMA failure in order for us to kind of like benefit for the patients. And I think I'm done here.
Wow, that was a lot of information. Both you guys are hitting it out of the park. Now we go to Teresa, which will make it a double or triple for us. And Teresa and I go back, 20 years, and I've watched her grow, and she's watched me get taller and bigger, but that's okay.
Well,
go ahead.
Thank
Teresa.
you. Well, thank you, Kelly. And I appreciate being invited to this meeting when we meet with the Midwest group, because many of the people I've connected with through my support group, through my work activities, in addition to my role as a nurse navigator at Mayo Clinic, I am part of the International Myeloma Foundation's Nurse Leadership Board. And I really give much of that credit to Dr. Maury Gertz, who, through his mentorship and recognition and promoting me as a candidate for the Nurse Leadership Board has really brought me to where I'm at right now in my knowledge and my ability to help patients. So today, what I really want to focus on is how to empower patients. I feel like I've been empowered through mentorship. I want to help patients as they experience this journey. Life is a canvas. You are the artist. I think Dr. Gertz has already demonstrated his artistic ability. And so with that, I want to focus on this idea of being empowered as a patient through education, which is a huge focus of mine. With that in mind, this idea of the information that Dr. Abdullah has so nicely presented, Dr. Gertz has presented, want to help to frame what we're going to be talking about in the next 20 minutes, which is this idea of shared decision-making, where to find reliable resources, know who your care team is, and then following it up with measures of looking at side effects, managing side effects, and quality of life. And when we think of shared decision-making, it really is about having this bi-directional conversation with your care team. But in order to do that, you really have to have a good sense of knowledge and where to find reliable sources of information. And even before understanding all about myeloma, it's important to understand what is important to you, understanding your priorities. What is it that you want to focus on, whether this is at the time of being newly diagnosed or at a point of a future relapse, like Dr. Abdullah has talked about. And throughout this entire journey, the International Myeloma Foundation continues to develop tools to help you concentrate your efforts to look at your objectives and your goals as far as managing your myeloma and the concepts of quality of life. And so there are a couple of tools that you can download at myeloma.org, a treatment discussion tool, which is very helpful, as well as things that you could be asking your doctor. So when we think about information that's available, you can go to Google and you can start to search information, but how do you know that it's a reliable source of information? And as dynamic as the field is, how current is that information? And so the International Myeloma Foundation really does have a lot of very current information. Dr. Dury does these very short snippets that make it very easy to digest a very focused topic of information. There are handbooks such as reviewing your test results, understanding bone disease, and then all the variety of therapies that have been discussed that you can learn more information about that. But who do you go to? Well, we think of the care team, and you and your care partner should be central to that care team, because every decision that is made impacts you more than it impacts anybody else. And so, for example, if you have questions about your myeloma, are you going to go to your primary care provider and ask them what is the next step in our treatment plan? Unlikely. You are either going to talk with your general hematologist or maybe periodically meet with a myeloma specialist for a second opinion. You're going to want to also have your primary care provider as part of your team so that you can talk with that person about general health maintenance, checking your cholesterol, your blood pressure, rather than spending that time with your myeloma specialist focusing on things other than myeloma. But don't forget about the other members of your care team, the allied health staff like myself as a nurse. I'm able to provide you with some guidance and answer questions or give you direction. Your pharmacists are amazingly knowledgeable about the different therapies, not to mention the subspecialists. Say you have the kidney disease that Dr. Gertz had mentioned, or bone disease that Dr. Gertz was talking about. These are people that you really want to envelop in your care team, be part of your collage. And of course, our support network from our social work group, our support family network, and support groups as a whole. I facilitate a group here out of Rochester that is done by Zoom. Today we would be meeting, so I have a big shout out to my group, just thanking them for pivoting to this meeting rather than having our standard meeting. But these are all forms of support, and members of your collage care team that you really want to embrace as part of your journey and learning on this journey. So now we're going to move into this concept of the color wheel of treatment. And it really is an interesting landscape. And Dr. Gertz and Dr. Abdullah have talked on many of these aspects in general. So we have this idea of initial therapy. And early on in the process, we are looking as healthcare providers, is this person somebody who might be eligible for transplant, or sort of from the get-go that they aren't? And many doctors will say, we're going to have to find a reason for them to not be eligible because, as Dr. Gertz has already mentioned, transplant is considered to be part of the standard of care for upfront therapy. And we'll talk a little bit more about that in a few slides from now. But there are some people who are not going to be transplant eligible, or they will choose to not go to transplant for their own reasons. Following transplant, there would be maintenance therapy, and then Dr. Abdullah has nicely talked on so many of the options that are available for the relapse setting. But incorporated through all of the treatment aspects, we also have to be thinking about supportive care, because supportive care adds to this landscape of treatment in order to provide supportive measures to improve quality of life. Now, this is a very colorful wheel of the many therapies broken down into the classes of drugs. And as Dr. Gertz had mentioned, there are certain therapies that we use in the frontline setting. Dr. Abdullah has talked about the relapse setting, and then touching on some of the therapies that are not quite yet ready for prime time, but we are hoping to get approved here in the near future. I'm not going to spend time on the individual therapies other than talking about a couple of the therapy approaches. And Dr. Gertz mentioned this in the bright and the dark side of steroids, in that we really do know that steroids, dexamethasone, is a very powerful therapy, especially at the time of initial diagnosis or at a point of relapse. There can be a point when a person does get off the steroids, or the doses can be adjusted, because people do have a lot of side effects. It's not easy on the day of dex when you're not able to sleep and your mood swings are flying. You're having a seafood diet. You see food, you must eat it. There are a lot of side effects that go with this, but it's important to understand that dose adjustments can be made in order to keep you on the therapy. That is just one of the key elements of managing side effects. And I think that was a really great question that came up in the chat box of, is a 15 milligram dose of Revlimid okay? Well, as Dr. Gertz said, it is better to have some of it and get some of the benefit of it rather than eliminating it altogether. And that's really one of the keys of managing side effects, is if side effects are not well managed, people are not going to tolerate the therapies. And that's one of the reasons that a very important clinical trial was done related to dexamethasone back in the day. And some of our long-term survivors will remember this, that people used to be on 40 milligrams of dexamethasone 4 days on, 4 days off, 4 days on, 4 days off. And it was kind of nightmarish for them. And it was through the very astute thinking of a surviving patient who said, do we really need that much dex, especially in the era of these novel agents? And so as a result of that, 40 milligrams of dex is given once a week with newly diagnosed or at time of relapse. And even though that's pretty miserable for that day, mainly for the spouse, it is overall more tolerable. And again, doses can be adjusted. Some of the things that I like to talk to people about is, are you taking the drug in the morning, right away in the morning with food? For some people, that works out really well. For some people who can maybe get up in the middle of the night, run to the bathroom. Yes, it happens for most of us. You could even take it during the middle of the night, as long as you take it with a snack. Get through some of those jittery feelings that you might have when you first take the drug, and then you're going to wake up a little bit early and wake up and maybe actually get some sleep the next evening, or even taking it right before you go to bed with a snack. That can be helpful as well. I think really important is that you don't change or stop the therapy on your own without talking with your provider. We know that there is a very synergistic benefit with dexamethasone and the other therapies. And so it's really important that you discuss this with your healthcare team so that you're not losing the benefit of this drug. The other area that I want to touch on in a little bit more detail from what Dr. Gertz had mentioned is this idea of the stem cell transplant, and very clearly the autologous or self-donated transplant. And as he mentioned, there are a lot of interconnecting ideas regarding this, whether it be at the time of a second transplant or even the first transplant. And right now, the current clinical data, as he mentioned, shows that transplant does provide a deeper and more durable response. People are getting greater levels of MRD, or minimal residual disease negativity, after transplant. And so it does continue to be a very important element or part of our treatment plan. There's data that hopefully will come out in the future, or clinical trials that will come out, that are really going to be showing this comparison of CAR T versus auto stem cell transplant in the upfront setting. And we will be looking forward to those results over time. But for now, we consider this to be the upfront treatment option for people who are eligible. And so I just want to break down this process, transplant by number, as I think of it, phases 1, 2, and 3. And I'm not going to go into a lot of detail because that could take us a whole hour in itself. But I know that people really want to understand what is their time commitment to this. Transplant is a commitment for patients and caregivers. And the first phase really is broken down into this concept of eligibility. We want to understand how the myeloma is responding to current therapy. We want to know if you, as an individual, are physically fit outward as well as inward. There are a lot of tests that we do to measure organ function and sort of an eyeball test to determine eligibility based on fitness versus frailty. In our country, insurance authorization plays a big role. And then as part of that eligibility, as Dr. Gertz has set the stage, this idea of collecting stem cells. We need to know that you can have the high-dose chemotherapy and the rescue of stem cells following in order for us to move ahead. This is about a 2-week time frame. If you put the week of testing followed by about a week of stem cell mobilization collection together, and this is done at the transplant center. Now, for some people, there can be a break between this phase 1 and phase 2 where we collect stem cells and we store them, whether it be for personal reasons or eligibility reasons, or you're on a clinical trial. But once we get to phase 2, whether it be a delay in there or not, this is the more intensive period of time where a person does receive the high-dose chemotherapy, that need for supportive care as the native bone marrow fails before the new stem cells start to grow, and we get to that point of engraftment. This is about a 3 or 4 week time frame. For some institutions, it may be an inpatient procedure. At Mayo Clinic, we initiate this as an outpatient, and for about 50 to 60% of the people, they will remain outpatient for the duration of the transplant process. But we do need you close by the medical center so that we can have daily monitoring and close monitoring in the event that side effects and symptoms emerge that require hospitalization. And then once a person does engraft, we reach phase 3, which is this transition from the medical center, allowing you to go home and recoup your energy, your appetite, re-strengthen before you begin maintenance therapy at that 2 to 3 month period after transplant. And so the overall time frame and commitment for the transplant process from beginning to end, where you begin to feel more like you again, is about 12 weeks. And what is the goal of all of this treatment that we've been talking about, from newly diagnosed to relapse setting, transplant, CAR T, bispecifics, a lot of therapies, what is our goal? Well, we want to get rapid and effective disease control. We want to make sure that that calcium level gets down. We want to get the bone disease under control. We want to get the myeloma under control. And we want it to be a durable response, because that durable response promotes overall survival. But this can't be irrespective of the concepts of quality of life, like Dr. Abdullah has been talking about. Our goal is not just to treat the myeloma, it's to treat the individual with myeloma and promote quality of life. And some of that can be done through supportive therapies, preventative maintenance, or preventative management, so that we can optimize quality of life. So there was a study done by Dr. Rosenthaler that, as I speak to this audience, you're probably all too well aware of, in the way of how myeloma greatly impacts quality of life in many domains of your life, from physical to psychological to financial. But I think the importance of this study is that it really does bring great awareness to what patients are experiencing, what people living with myeloma are experiencing. We may assume as healthcare providers that it's all about pain and neuropathy, but fatigue is very common for people, and oftentimes is dismissed because it is so common. We'll be talking a little bit here in the next slide about fatigue and depression, but constipation. Some people actually have diarrhea, and we'll talk a bit about that as well. Some of the psychological aspects, and this addresses a little bit more with the caregiver, or includes the caregiver, is this idea of change in role function and social function, and that has a big impact on people's quality of life as well. So, there are good reasons for people to have anxiety and depression related to this diagnosis. Nobody is going to say, why are you feeling that way? You put somebody with a new diagnosis, or maybe a point of relapse, concern financially of how they're going to afford their treatments. They're immunocompromised, and here we are in a global pandemic. There are a lot of reasons for people to have anxiety that can promote depression, that can promote fatigue. And the other causes of fatigue simply related to being human, being sleep deprived, and then having issues with anemia and pain. Myeloma can cause inactivity, and believe it or not, the less active you are, the more fatigued you become. And in answer to the question that had come up earlier, one of the things to really think about if you're off therapy and you are having a lot of fatigue is, have you started to re-engage in a physical activity plan? Because that will actually help a lot of the symptomology that comes from myeloma, from fatigue to depression to even neuropathy. But I think it's really important to understand that for many people, good 75% of people are experiencing anxiety and depression, but they're really not talking about it. So please bring these ideas, these concerns to your healthcare team. There are medications, meditation, support groups that can be helpful, professional therapists, not only for you as the patient, but as for your caregiver as well. So if you at any point ever have a sense of self-harm, concern for suicide, or you see that in your loved one, please seek help. GI symptoms are very common throughout this whole process of treatment. In the course of transplant, of course, there's issues of nausea and diarrhea. With pain medication, people can have a lot of constipation issues. Revlimid and Velcade can sort of toggle between constipation and diarrhea. It's important to assess this periodically, because infection, which is very common in myeloma patients, there can be the risk of something called C. difficile. We want to make sure that that is not a contributing factor, that we check a stool specimen if this has been an ongoing thing. There can also be a sister diagnosis of something called amyloidosis that can affect the bowel. But more commonly, there are medications that are impacting the bowel function. And so, for example, let's say you're newly diagnosed, you have bone related pain, and you're put on an opioid, you're put on some pain medication. And with that, then you're put on a stool softener because you're having a lot of constipation issues and maybe you weren't quite as mobile. Well, you get your myeloma therapy going. Maybe you've had some radiation to help with some of that bone pain. You get rid of the pain medication, but you haven't gotten rid of the stool softener yet. And here you're experiencing diarrhea. Maybe we need to look at your pill box. So there are a variety of things that we can look at depending on what your symptoms are in respect to addressing the diarrhea or the constipation. I actually like to tell people if you're having either, put an apple in your diet every day. If you recall grandma making jam in the kitchen, she used pectin. That white part of the apple is pectin. It will draw fluid into it to make things more solid, or it'll draw fluid in to make solid more loose. And so they always say an apple a day keeps the doctor away. But with all of this, it's really important that you maintain hydration, good fluid intake, because if you're having diarrhea, you need to replace that fluid. If you're having constipation, you need that fluid to help loosen up the stool. Pain does have a huge impact on people's quality of life, but there are many sources of pain. Some of you may be experiencing neuropathy related to therapy. Some of you may be experiencing bone related pain due to the fractures that Dr. Gertz was talking about at time of being newly diagnosed, or even at a point of relapse. But even medical procedures can become a nuisance. Bone marrow biopsies can be very painful when your toes are being sucked through your hips. It's not a great experience. And so I think we need to think about ways of managing pain. When it comes to, and it depends on where your source of pain is. When it's bone related pain, we want to prevent that with the use of things called bisphosphonates or bone strengtheners. You may know them more commonly as Zometa or Iridia, and then there's something called denosumab Xgeva, which is a monoclonal antibody that can also reduce bone fractures. We know that some of the therapies can increase your risk of shingles, which can cause neuropathic pain, which is different than neuropathy, and so we want to use preventative medications in that way. I love the idea of doing a sedated bone marrow biopsy rather than one when you're wide awake. And combining procedures to reduce the pain that you may experience. Even a simple blood draw is no longer simple when you're being poked repeatedly. Maybe talk with that primary care doctor and coordinate with your hematologist if you're needing your annual healthcare labs. Maybe you can have them combined into one blood draw so you don't have to have multiple pokes. There are other things that we can do in the way of physical therapy to help re-strengthen the musculature that's going to help to support your back now that your spine, that column of vertebrae is no longer fully intact. There may be need for surgical intervention, whether it be to prevent a fracture, maybe a fracture has already happened. Radiation therapy can be done also in the way of reducing pain, but we have to use that a bit sparingly because that does, in all effects, burn the soil of that area that is being radiated. So we use that a bit cautiously. I think it's also a good idea to expand into some of these ideas of the complementary therapies. Meditation and medication are simply one letter apart, but they can be used in combination to really improve pain management and quality of life. One of the things that was mentioned by Dr. Gertz as he talked about the immunoglobulins and the paraproteins and these plasma cells that are normally supposed to be there to protect you from infection, but go haywire. They are overproduced in excess and are no longer as functional. They actually increase a person's risk of infection. And of course, the treatment does as well. And so people with multiple myeloma are at greater risk of infection. That comes from things that are already in your system, especially during the course of transplant, or things that you can gather from outside, things like COVID, things like influenza. And so we need to be really watchful of any signs of infection because we consider infection to be a medical emergency in people with multiple myeloma. Fever is one of the telltale signs of infection, but there can be other signs like redness at a site, respiratory symptoms. It may be that you need additional support in the way of growth factor or immunoglobulin infusion to enhance your immune system. But we do know that immunizations, whether you can fully mount an immune response or not, at least may provide some benefit to reducing your risk of things like influenza and COVID. Personal hygiene, of course, is important, from oral care to full body skin care, and then environmental control. The things that we're telling people right now about managing or preventing COVID infection from masking, avoiding people, good hand washing. This is something that we have professed in the world of myeloma and in transplant well before COVID ever became popular. So to touch on one more thing in this 3 domain areas, this idea of financial burden. And as Dr. Gertz mentioned, these medications are not cheap. And for some people, they can find support either through their insurance company and have great copay assistance through medication companies. Even some of the clinical trials, like Dr. Abdullah was mentioning, they will have travel expense assistance. And so these are some areas that we can look at to try and reduce the burden. There are also some websites that I have listed here, and I believe you'll get a copy of these slides that have assistance programs available for medications, for lodging, for even insurance premiums, as well as travel expenses. So talk to your social worker, check with your resources on what options may be available if you're finding some challenges with expenses. For example, here in Rochester, we have something called the Gift of Life Transplant House, which is similar to that of a Ronald McDonald House, but for adults who are undergoing transplant. And it's a community-based setting that allows people to have a very comfortable living situation at a very affordable price. And so then I just want to touch on this idea of healthful living, what you can do to be a part of this promotion of quality of life. Managing your stress. We all are under stress, and having a diagnosis of myeloma in the middle of a global pandemic is by all means a source of stress. So good rest, relaxation. I love the meditation that we had done. There's something called sleep hygiene. For most Americans, we are sleep deprived, and getting into a habit or a routine of engaging your body to let it know that it's ready to go to sleep is really important. Social engagements and mental health is really important, and even seeking professional help if needed. As I mentioned, I facilitate a support group, and there are support groups throughout the country that you can find at myeloma.org. And these are readily available at multiple times and days of the week that can fit your schedule. Dr. Gertz had already talked about sort of the nutrition aspect of healthy weight, and activity and exercise can really be promotional in the way of energy level and helping to reduce some of your symptoms. You need to maintain good renal health, and hydration is so important. As you had mentioned, about a third of the people will experience some degree of kidney dysfunction. Maintaining good hydration is really going to be important in that respect, as well as avoiding what we can in the way of renally toxic drugs. For people who may have borderline diabetes or active diabetes, we know that dexamethasone can have a big impact on dexamethasone can have a big impact on your diabetes, which can have a negative impact on your kidneys. So another reason to help your kidneys is to keep your diabetes well managed. Bone health, as I mentioned, the bisphosphonate therapies, as well as weight-bearing activity. Many of your doctors will prescribe calcium plus D as a way of helping to promote bone health. And then things like doing your annual medical visits, preventative health maintenance. If you're a smoker, please stop. Dental care is really important and something that we promote, especially prior to starting bisphosphonate therapies or even before you undergo stem cell transplant. Benjamin Franklin said an ounce of prevention is worth a pound of cure. And I think that holds true in this setting as well. So I just want to remind everybody that, knowledge really is power. And the International Myeloma Foundation, in addition to this seminar, has many other educational offerings. There's also support offered through the support group network that is available throughout the country. And I encourage you to take advantage of the seminars that are available, the educational resources and tools that are available on their website, and always talk with your healthcare team when you're having new challenges, whether it be financial, psychological, physical, and seek a second opinion at a point when you feel that there are pivotal decisions that are needing to be made. So with that, Kelly, I'm going to hand it back to you.
Wow. God, you guys are just fantastic today. Thank you, Teresa. That was wonderful. If I can bring the whole panel back here, I've got a couple of questions that anyone can answer here. Let's see. I am depressed because of myeloma, which we all understand that out there. My oncologist prescribed Xanax, although should I go see a psychiatrist for this kind of thing as opposed to taking Xanax and getting on other drugs? Anyone want to answer that?
Well, I'm happy to start out and say I think it is a multi-team approach. And I don't think there's any reason to not be meeting with a psychologist or a psychiatrist to help with your depression. And because there is a polypharmacy situation where there are many medications that are being used for many different reasons, I think it's also important to have the pharmacists engaged with some of this discussion because there can be medication interactions. I myself am not in a position to say yes or no to Xanax or anxiety medications, but I do think it does take a multi-team approach.
That's great. One gentleman just came up with, I have chest sweats in early morning. Can it be a side effect of my myeloma medication or myeloma itself? Dr. Agula?
I think it needs to be elaborated a little bit more, about what does he mean chest sweats and what treatment he's on, and
Sure.
What's the status of his myeloma? There's a lot of vagueness, I'll say the word, is his myeloma in remission or is he on, there's a lot of question. I have a lot of patients when they come with side effects and you talk to them more deeply. I mean, they will give you a different version. You approach them differently, but I think there's a lot of questions about what's the status of the disease.
Yes.
For example, what treatment he's on, and have he been off the treatment and the treatment has, in general, I'm going to be very honest. Here's what I do. If I have a suspicion that there's a treatment that's causing side effects and the myeloma is, let's say, is responding to the treatment, I give the patient a break from the treatment in order to identify if that side effect is related to the treatment or not. If it goes away, which most of the time it happens, I kind of evaluate to adjust the dose or see exactly what I need to do in terms of the frequency. So if my suspicion about the treatment, I usually kind of like hold it if there's no any any concerns about the myeloma. So it's really not one of the side effects that I commonly see in myeloma patients, but it has a lot of questions about what exactly the status of the disease, what he's getting, and many things. Did it start when he started a new treatment or?
Oh.
I have had members of my support group mention that the dexamethasone will cause them to have sweats, whether it be chest or head or night or day. And so you might, in addition to what Dr. Abdullah has mentioned, would say maybe track a pattern, if there is a pattern to this, and see if there is an association that you can make with any one of the therapies.
We have a question about Xgeva. I'm 79 years old, a male, diagnosed in September 2018 with Kappa light chain. Let me go down here in the question a little more. I was taking Xgeva monthly, but now my doctor says to take it every 3 months. Is there controversy with Xgeva and bisphosphonates, Dr. Gertz?
One of the problems with Xgeva is that you're not supposed to stop it abruptly because it can cause rebound on the blood calcium and can lead to fracture. And so we tend to prefer at Mayo Clinic bisphosphonates over Xgeva. We save Xgeva for those patients that have impaired kidney function. So in this situation, you probably, when you discontinue Xgeva, will need 1 or 2 doses of a bisphosphonate as you go to reduce frequency. And in fact, we stopped giving bone repairing medicines that help strengthen the bone in patients who are in very, very deep remissions, because our experience has been that people who have very, very deep remissions have very low risk of developing a new bone lesion.
Excellent. Now, one person here who's gone through several treatments, but is a little confused with CAR T. Why do they not use CAR T in the beginning with myeloma? Dr. Abdullah?
Well, we have to go backward and ask ourselves exactly what's the standard of care, and the standard of care is stem cell transplant. There's a lot of evidence that show transplant is superior to a lot of treatments. And the last, I think, what was the 40 trial actually, which they compare transplant versus no transplant, and they use different induction therapy, and it shows there is a benefit. The other trial also that they compare RVD transplant versus RVD alone, and also there was a longer progression-free survival. We go with randomized trials, not to say that we're against any trials to compare CAR T versus transplant, but we need these trials in order to prove itself. We have seen longer remission in these patients, like the IMF trial that showed that at 8 years, the progression-free survival was around 38%. That's a high number, and we don't have any evidence about other treatments. We're happy with the CAR T cell. We're happy with the accomplishment of CAR T cell, but without a randomized trial to compare it head-to-head with stem cell transplant, I think it's just a speculation from our standpoint, like it's good, it's going to work, it's going to keep patients in remission. But we really need a randomized trial. If CAR T cell prove it is as good as stem cell transplant, that is the first thing that we have to do, is substitute transplant with CAR T cell. That's my opinion. But until now, we can't just based on in relapse myeloma. We can't do the same mistake we did with carfilzomib. Carfilzomib was working better in the Velcade, and we did a randomized trial, and we did it actually comparing to carfilzomib and Velcade, and it was the same. So we always kind of assume that the drug that works later is better, but when we start doing a randomized trial, we start seeing if it's better or not. So in order for CAR T cell to actually replace transplant, we need a randomized trial. If it proves it's as good as transplant, I think that's more than enough to kind of like move it forward and become a standard of care. But until then, I still, believe that it have to be actually in where is it placed in relapse myeloma.
We've had this question come up a couple of times today. What is the risk of secondary cancer due to the stem cell transplant, SCT? Maury, would you like to take that question, or have you heard anything?
Risk of second cancers in patients who have a stem cell transplant followed by Revlimid maintenance therapy is approximately 6%. In patients who have not undergone that, just standard myeloma, the risk of second cancer is 3%. So it increases it by 3% or doubles it, depending on how you want to look at it. And right now, approximately 90% of myeloma patients end up dying of myeloma. So in my practice, although there clearly is an increased risk of second cancers, it doesn't enter into the decision-making process because the risk of dying of myeloma is 30 times that of a second cancer.
Okay. Let's see several questions about MRD testing. Should we do it even if we are doing well with treatment? Is one question. Minimal residual disease. Dr. Abdullah, would you like to take that question?
Well, I have a lot of controversial, I have a lot of opinions about that. And one of my opinions is that if you see the MRD is negative or positive, what are you going to do clinically? That's the most important question. And I'm not against testing it in the clinical trials. We really need to know what we need to do with these MRD testing. I don't want to just ask the patient, I'm going to give you a certificate, you're MRD negative, but you're still going to continue the treatment. I want to tell the patient, if your MRD is negative, that this is my goal. I'm going to stop the treatment. I'm going to observe you. I don't want to be that physician who's just going to post it out like, oh, I got 20 plus patients MRD negative. That means you're going to live longer or you're in remission. We need more clinical correlations. There's a lot of great clinical trials outside there that we're seeing that is going to try to utilize this MRD clinically. Utilizing the MRD clinically is more important, not only just achieving it or measuring it. And one of these trials that I'm actually impressed about is the dramatic trial, the Revlimid versus Revlimid in maintenance therapy. What this trial is going to do is that they're going to take these patients after 2 years of maintenance therapy, measure their MRD. If they're negative, they're re-randomize these patients to either stop the treatment or continue the treatment. That's really critical and important because that will tell me what clinically I'm going to benefit from these patients. Now, saying so, I don't have like any problem to measure it, but is it going to actually change my opinion? You know, and I think that some oncologists may make their decision saying I'm going to use the master trial, which is still also not really significant, a big trial that actually gives us a clue about long-term how it will impact. I'm very biased about that. I really want to see more studies and really want to see more evidence, clinical evidence about what can this do clinically for patients. I'm waiting for the dramatic trial. It takes time, but I think that's one thing I will actually be very concerned. Number two, also, there have been a lot of questions about what type of MRD you're talking about, 10 to the minus 5, 10 to the minus 6, the flow cytometry, the next generation. We're not even like yet there, to actually measure that.
Oh, goodness. Here, just ask, melatonin and Revlimid interactions, are there? Dr. Gertz?
Don't know.
Okay. All right. When is it safe to stop using a blood thinner? I have been on Eliquis for 6 months and would like to stop. Is there more details you need for that patient?
Why is he taking the Eliquis? I think that's the first question.
That would be the question, yeah.
Yeah, I mean, if he's taking, most of my patient, if they're taking Eliquis, it's for an AFib, so I usually defer that to the cardiologist. But if it was for Revlimid, just kind of like evaluate what was the reason.
Reiterating fact that you do need a team of professionals helping you through this process and other options that Teresa discussed. I wanted to tell everyone that's listening, to a lot of you out there, this program has been recorded and will be on our website. You can either go through just the slides, or you can go through Maury's talk, or you can go through Ola's talk or Teresa's talk, but it's a slower process. Now, the other aspect of these questions, you've heard them, you can also email the infoline at myeloma.org. So it's just infoline at myeloma.org, and they'll help you out. It seems like we don't have any more questions, so I wanted to thank everyone that participated, and we appreciate your time on a Saturday. I know you're very busy, and I do appreciate it. So with a couple of things I want to go over. The feedback survey is incredibly important. I've said it a couple of times. We will email you back shortly after the workshop, and please take a moment to complete the survey. One thing that comes to mind here is that we've used a couple of acronyms. On the website, we have an acronym list that might help you out when they say PFS, things like that, I think that you'll feel a little more comfortable with it. Oh, and Mr. Let's see. On Eliquis, because blood clots showed up while on Revlimid. There's some more information. Let's go back to that question before I wrap up here. Does that make more sense to you, Dr. Abdullah?
Well, yeah. I mean, when was that? The patient stopped Revlimid, or he's still on Revlimid?
He's still on Revlimid.
If he's still on Revlimid, I will still continue that. He's a high risk for developing it. So I'm assuming he's still on Revlimid, if I'm not mistaken.
Clots showed up while on Revlimid. Yes. Well, that's a tough question. I'd like, sir, for you to call the info line, and they'll help you out quite a bit. Quickly, thank you to our sponsors, Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda, and for the great participation of two wonderful doctors and very smart, and Teresa, a wonderful nurse and very smart too. You're not alone out there anymore. For those of you on dexamethasone, our website's up all the time, and we ask you not to vacuum, but just to get on the website and get some help. My name is Kelly Cox. I'm the Director of Support Groups and Regional Community Workshops. I want to thank everyone for being on here. And again, have a great weekend.
Thank you very much.
Thank you.